Sorry, I think my title is changed. Okay, I am Dr. Naruma I.B. Haidar Chaudhary, Assistant Professor, Pediatric Cardiology of Department of National Heart Foundation. Welcome you once again, and respected chairperson, honorable panelists, and my dear senior junior colleagues. Does the coronary arteries it the only for the adult cardiologist? Being a pediatric cardiologist, I want to share some coronary anomaly that has clinical implication in the diagnosis and management purpose. So we know that congenital coronary artery anomaly is very rare. It is only 0.2 to 1.2% of the general population. And the different coronary anomaly that I'm going to share in next few slides, that is single sinus, double ostium coronary artery, intramural coronary artery, single ostium left anterior descending coronary artery crossing right ventricular outflow tract, anomalous origin of the left coronary artery from the pulmonary artery that is labeled as L kappa. So before going to my presentation, just I want to show the normal anatomy of the coronary artery. This is the left sinus, this is the right sinus, and from left sinus, the left coronary dividing into LCX and LAD and crossing over the main pulmonary artery, and the right coronary artery arises from the right sinus. How it looks in the echo. From the left sinus, this is the left coronary and this is the right coronary artery. So my first case, who only presented in 1 month, 9-day male child, who having presented us in a critical ill condition, almost in a shock-like state, and having only saturation 40%, and diagnosed as a case of dextrocardia with transposed great artery, with closing patent foramen ovale, and with coronary anomaly. We take the patient into the cath lab for the palliative balloon-lateral septostomy as the patient is almost in a dying state. And after the initial recovery, we take the patient to the OT and we operated the child for arterial switch operation and we discharged the patient. And this is the dextrocardia and this is the TGA-LV giving rise to the branch PA and anteriorly placed RV giving rise to aorta, and this is almost closing PA4, that is right to left shunt. And if we see, this is the posteriorly placed pulmonary and this is anteriorly placed aorta. And if we see that right coronary and the left coronary artery is arising from the left sinus, rather this right coronary should arise from this right sinus. And if we just look at this freeze frame, then we will find that both have from the single sinus, that is left sinus. And if we more carefully look, that the proximal portion of the left and right coronary is intramural. This is very rare. And if you see the diagram, this is the intramural part of this is just duplication of this in our image. So we have taken the patient for BAS and we find the same things, that the left coronary and right coronary is arising from the single left sinus. And this is the perioperative finding. This is a dextrocardia and surgery, arterial switch operation was done and transected the pulmonary artery and the aorta. If we see carefully, this is the two ostium from the left sinus. And if this is the zoom view where the surgeon has unroofed the bilateral intramural coronary artery and we can delineate the left and right coronary intramural part. It is very important because arterial switch operation is itself a very complex one where the most chance of the mortality. And if the surgeon knows on table that this is the intramural coronary, which is become more complex, the surgery complication will be more worse. So if we can give this impression prior to the surgery, then surgeon will go to the cool head and pre-set up mind and he can do the surgery accordingly and can counsel the parents also. My second case is 2-year, 7-month female child having the bluish discoloration with spell attack, diagnosed at tetralogy fellow with coronary anomaly. Let's see what is the anomaly here. If we see here, this is the coronary artery. This is bifurcating into two. What in steel frame, if we see, this is a single origin and this is the right coronary artery and this is the left coronary artery. And previously we have seen that left coronary will arise from here and right coronary from here. So we are finding that the both coronary having single ostium and this left coronary is crossing RVOT. This is not a usual course because if surgeon do the pulmonary valve repair, they give the incision at RVOT. At that time, this LAD can be sacrificed so that we also can, the echocardiographer help here also. If we give these impressions, surgeon can decide and change the strategy. This is a normal heart. If we see this from this left sinus, the left coronary is arising and going in between the aorta and pulmonary, and this is the course. It goes anterior interventricular groove and posterior interventricular groove. But what happened in our case, we found that this is single ostium and both are arising from the single sinus, and this is the LAD which is crossing across the RVOD. So if surgeon give the incision here, then LAD will be sacrificed. So surgeon has made the decision change, and they done the Rastelli operation where the conduit is used and RV to PA conduit is used, and they have not given any incision. This is also very important because if the echocardiographer gives this impression earlier, then the conduit price and the complication, then conduit can be changed, or complication of conduit can also be explained to the parents, and surgeon is also pre-planned setup mind.
Ma'am, 1 minute left, please. Time is very short.
This is my last case, 7-month female child and having the features of heart failure, and this is the abnormal origin of the left coronary from the pulmonary artery with severe LV dysfunction. This is very rare. If we think what is happening here, the anomaly artery is arising from the pulmonary at birth. During it is the direction will be antegrade because the PA pressure is high. But what happens after birth? PA pressure comes down, so it is collateral develops and retrograde field, and this is the how we can diagnose this retrograde field. So in 2D, we find that the LAD is arising from the aorta and it is antegrade from yellow jet because towards the pointer. But here we find that it is arising from the pulmonary artery, well delineated, and the color flow is changed because the flow direction is changed. And as because the LAD is sacrificed, so LAD is hampered, so there will be LV dysfunction and papillary muscle scarring and can produce MR. So this patient also translocation done. This is the coronary which arising from the pulmonary, and translocation was done. So this is the post-operative. We can see the good aorta from the aorta is translocated to the aorta. So the take-home message is coronary anomaly in congenital heart disease is a rare condition, and echocardiography is an essential tool to diagnose, and in most cases replacing the need in invasive angiography and pre-procedure identification can reduce many life-threatening complications and help in counseling about the prognostic and cost factor. And echocardiographic diagnosis is not an easy task, but practice and perseverance can bring the success. I must acknowledge our strong surgical team who has given a good support and good criticism to us. Those we have to be keen, and awareness precedes choice and choice precedes result. Thank you all for being with me.
Thank you, ma'am, for your extraordinary presentation. May I request Khaled Mohsin sir to comment in this case, please?
Nahruma, it's a very beautiful presentation. Actually, when in MD cardiology, we were taught that one of the indication of cardiac catheterization in patients of tetralogy fallot undergoing surgery is to look for an anomalous coronary. This is crossing the RVOT. So nowadays, I probably with this type of expertise in our pediatric cardiologist, I think the invasive assessment is relegated to a very limited number of cases. So we have to keep our index of suspicion very high, and we can take appropriate measures in time before there is irreversible change in the LV. If we do the surgical correction after the heart dilates or the papillary muscle atrophies, it will not be a long-term outcome. So we have to detect in a very early stage of the illness. So thanks to Nahruma and all the pediatric cardiologists. So they're doing a very nice job by very early detection and early referral to the cardiac surgeons. So thank you very much.